As you guys all know, I'm Katie, and today we're going to talk about POCUS ocular ultrasound, but we're not going to talk about pathology. So that was last week. So we're going to look at trauma and swelling and some of the other conditions, but we're not going to cover every single ocular pathology that's possibly seen by ultrasound. So more of the common things that we're actually going to see when you're in the emergency room. So in terms of the objectives, we'll go over the technique, because I'd like this to be a standalone lecture, indications, pathology, pitfalls and limitations, and then we'll go through some of the literature big hits as well. If you have questions anytime, guys, feel free to interrupt, please just ask. Like I said, what we're not going to cover papilledema, that was last week's session. So if you want to read more about it or hear more about it, then look at Mark's lecture from last week. So in terms of our transducers, as you guys know, it's going to be the high frequency linear transducer. And the reason you want shallow penetration, you want high detail. So you want to be able to see the anterior chamber, the posterior chamber, as well as the retina and the retroorbital space. In terms of the position, lots of different ways you can do it. It's talked about differently in the literature. So having the patient at 45 degrees, having them lying down, having them sitting. And as we all know with children, sometimes they don't like to participate in certain exams. So using the same type of hold that you would use to look in their ears or mouth to do the eye. So holding them in the parent's arms. In terms of the technique, you want to have the transducer perpendicular to the it's very important to use a large amount of gel. You want this transducer floating, so you don't want to put any pressure on the eye. Important to balance your hand on their face, so somehow on their forehead, on their nose, somewhere comfortably and gently so that you can have balance and you can get the fine movements that you're going to need. In terms of pressure, make sure it's gentle. You don't want to cause discomfort. I'm sure you guys know if you push on your eyes, it's not the most comfortable thing. So we don't want to make the children uncomfortable when you're scanning them, so minimal pressure. Other things you can do, so convention would be sitting on their right side, but you can also go behind. And then that way you're actually putting your palm on their forehead, and it sometimes finds it a little bit more easier in that position. So in terms of equipment, obviously your standard ultrasound machine, your probes, your gel, but one of the things that we tend to use here and is also described in the literature is a bio-occlusive dressing. So we tend to use Tegaderm because it's a protective barrier. The other thing to use is some sort of equipment to make the children comfortable and happy and something they can track. So young kids aren't going to look right, look left when you ask them to, but if you put something in front of them and you have their other eye open, you can get them to track in the areas that you want them to. So here's a picture of our lovely Tegaderm. I think this is Leanne. This is basically the eye, as you guys know, it's a mucous membrane, so there are some infectious disease concerns potentially. So by putting the Tegaderm on top, you're minimizing this infection. Excuse me. You can then have this eye closed and still have the other eye open because it's easy to have one eye closed and because it's being held down with the other one open, so kids can still look and see and feel more comfortable. This allows for good cleanup because then you just basically remove the Tegaderm and most of your gel is gone. Important to take any, so you can see there's a little bit of air in this picture underneath. Oh, it's not showing up now. Okay. So a little bit of air underneath. So you want any of that air to be removed. That way you, the air for ultrasound is our enemy. We can't see through it very well. So you want to make sure there's no air there if possible. When you're going to take these off, the easiest way is to pull in the direction of the eyebrows, the way the hair is growing, and that way avoid any unnecessary discomfort to the eyebrows or eyelashes. But as you know, it does not take off your eyebrows and eyelashes. It does remove makeup, however. So those teenage girls or guys who are wearing makeup would be a thing just to let them know. So in terms of the technique, important to scan both your affected eye and your uninfected eye for comparison. Ensure that your depth is adequate. So you actually want to see like not just the optic nerve, like the retina, but you want to see behind it as well. So you want to see your retroorbital space. Ensure to look in both your transverse and your longitudinal planes. And then ask the patient when they're in both of those planes to look left and right or up and down. So for your oculokinetic echography, and this will allow clear exam of the vitreous abnormalities back within the posterior chamber. Again, increase your gain slowly and decrease your gain slowly while they're moving their eyes down, and that way you can see the full chamber and have fully assessed it. We'll go over that in a little bit more detail. So in terms of your which settings to pick, it's very important to pick your ocular setting. So the reason that this is you want to have a low mechanical index, so less than 0.23, and a low thermal index, so less than 1. The reasons behind this are really theoretical, but potentially you can cause injury to the eye, so things such as cataracts. This is also the reason to limit the duration of your exam, because the longer that you're there, all your ultrasound waves will turn into heat, which could potentially injure the eye. Again, this is all theoretical. There's no evidence that they're in human tissue that this has caused any concerns, but we're still taking a conservative approach. Same thing goes for color Doppler for the exact same reasons. The ultrasound beams turn into their thermal energy, which potentially could injure the eye. Again, this is theoretical, so we're not using color Doppler on our scans. In terms of some tips and tricks, so again, remember your ocular setting, use lots and lots of gel. You want to be floating above this eye. Put your tegaderm cover on and engage the child for your best exam. So moving on to indications, there's lots of indications. Again, always the concern for increased ICP is one of the indications. I didn't put it on here because that's not what we're looking for in this talk. So loss of vision or vision change, especially acute change, any sort of ocular pain, known ocular trauma, an abnormal red reflex, and a swollen eye. As you guys know, it does not assess visual acuity or visual field, so it also does not replace CT or MRI if they're indicated. The one contraindication is globe rupture. So because of this, when the eye is open, you risk extrusion of further contents, bleeding, and introduction of infection. So we would say if you have globe rupture or suspected globe rupture, or you put the probe on and you're like, oh, it's a globe rupture, then you should stop your exam. The other thing about globe rupture is actually the contour is going to be more irregular and then very hard to see the pathology that you're looking for within the eye. So in terms of pathology, these are some of the things we're going to go through today, although you can see other pathology that I'm not going to be talking about. So retinal detachments, vitreous, posterior vitreous detachment, vitreous hemorrhage, foreign bodies within the eye, lens dislocations, mass, so such as retinoblastoma, extraocular movements, and your pupillary reflex. So back to our anatomy. I'm sure you guys all remember this from medical school. So the things that you really want to see, pardon?
Every single
Every single term. Don't worry about all the terms. Basically, anterior chamber, lens, posterior chamber, the optic nerve sheath, and then the retina back here. So those are the things that you really want to know quite well. So here's a normal eye. So things that you can see, anterior chambers up here. There's the lens coming in. This is the posterior chamber. Here's the optic nerve and the optic nerve sheath, and here's the retina on the back. And then this is the retroorbital space, so you get used to seeing the normal retroorbital space after you have seen multiple ocular exams. So tips and tricks, it does not assess the orbital bone. So if you're concerned about an orbital fracture, this is not the test for you. So you're going to need a CT.